Welcome to Preventing Firearm-Related Injury and Death, a Targeted Intervention. My name's Garen Wintemute. I'm an ER doc, and I became involved in firearm violence prevention because I believe there's a moral imperative to prevent firearm-related harm that's every bit as compelling as the moral imperative to treat it. There's a practical reason, too. Most people who die from firearm injuries never make it to the hospital. They die where they're shot. To prevent deaths from firearms, we need to prevent people from getting shot in the first place.
I'm Emmy Betts, and I'm joining the conversation from the University of Colorado School of Medicine. I'm also an ER doc, and probably like most of you, I've lost family members and friends to suicide. I also care for patients who've been hurt by firearms or at risk of future firearm injury or death. I work on this issue to help patients I care for and to help the many who might not make it to my ER.
I'm Megan Ranney, an emergency physician from Alpert Medical School at Brown University. I'm involved in this work because all of us as physicians have stories of patients hurt or killed by gunshot wounds who we wished we could have saved. But most of us also have personal stories about the way that gun violence has affected us. It's time to do better for our patients and for our communities.
I'm Rocco Palin, and I'm the director of the What You Can Do initiative. As researchers, my colleagues and I study the causes and consequences of firearm violence, but we want to do more. Our goal is to translate that knowledge into strategies for preventing firearm-related harm, including helping healthcare providers play a role in reducing firearm injury and death.
We're going to take a comprehensive look at firearm injury and death. We'll lay groundwork for thinking of firearm-related harm as a public health problem, and we'll cover the epidemiology of firearm injury and death in the United States.
It's essential we think about firearm-related harm as a public health problem, and that we conduct translational research on how to move from basic knowledge to effective prevention efforts. But what can we do now while we wait for those research results?
As healthcare providers and as thought leaders in our communities, there is a simple, targeted intervention that all of us can start using now. It doesn't deal with policy or partisanship. It simply takes place within the context of routine patient care with the patients with whom we're already interacting. And it's not about asking everyone if they have a firearm. When you feel that patients may be at risk of firearm injury, first, talk to them about access to firearms. Second, provide counseling on safe firearm practices when appropriate. And third, take action when the risk is acute and someone is in imminent danger.
This is the bulk of what we're here to talk about: the who, what, where, and how of clinical counseling for reducing the risk of firearm injury and death. And you don't have to own a gun or even have used one to discuss firearm safety with your patients. You just need to learn about it, just as you've learned to talk about insulin or similar medications with your patients, even if you've never used them yourself.
Let's start with a little background on this project. This presentation is part of the What You Can Do initiative, which we developed following the mass shooting in Las Vegas, Nevada in October of 2017.
For many years, I'd heard from providers who wanted to get involved in firearm injury prevention, but who didn't know where to start. After Las Vegas, interest grew rapidly. I wrote a commentary in Annals of Internal Medicine asking readers to make public commitments to provide counseling on firearms. We solicited feedback on how often providers ask and what reasons they have for not asking when they don't.
We learned that providers needed help in two ways. They needed more information on how to identify risk factors and how to ask the firearm questions, and they needed materials on firearm safety to give to their patients.
The material that we'll cover is derived from the best research in the field and from expert opinion where research is lacking. The science that would support or define a most effective clinical strategy for preventing firearm injury and death is incomplete, but our patients can't afford for us to wait.
Dr. David Satcher, director of the Centers for Disease Control, said of violence in 1993, "If it's not a health problem, then why are all those people dying from it?" In the 21st century, at least so far, we've made little progress in reducing firearm deaths.
Let's take a look at all those people he was referring to. Who are they? How are they dying? And what can we make of the geographic and demographic trends in firearm deaths? It shouldn't surprise us that deaths from firearms vary geographically. Firearm injury and death affect the entire country, but in different ways. This we should expect, firearm ownership and use also vary across the country and significantly between rural and urban areas.
Here's another look at geographic patterns of firearm deaths. One important finding is that homicide is highest in the South, while suicide rates are highest in the intermountain states like Montana and Wyoming. When we dive deeper into the data, we learn how people are dying from firearms in the U.S. The results can be surprising. For example, only about 1 to 2% of firearm deaths occur in public mass shootings.
With other types of firearm-related harm, many of us can pretend that we're not affected. But mass shootings don't allow us to ignore that we too could be victims. That said, we believe that the attention of policymakers and the attention of healthcare providers should be on the prevention of all forms of firearm-related harms, not just mass shootings. So let's take that broader look. In the United States in recent years, there have been nearly 40,000 deaths from firearms and more than 115,000 non-fatal injuries annually. Nearly 2/3 of deaths are suicides. Most of the other third were homicides. The annual cost of firearm injury and death was estimated as being $229 billion in 2012 alone, including $8.6 billion in direct costs, things like healthcare. The broad spectrum of all types of firearm-related harms is where we, as providers, have an ability to help our patients.
Research largely stalled more than 20 years ago, and perhaps as a result, comprehensive intervention has been lacking. But it does not have to be that way. Let's take a look at another and analogous public health problem.
These days, similar numbers of people die from firearm injury as from motor vehicles each year. But the long-term downward trend in motor vehicle deaths, especially considering increasing numbers of drivers and miles driven, is proof of what public health interventions can do.
With motor vehicle injuries, we faced a crisis, recognized an epidemic, and decided to do something about it. Research was prioritized and funding was allocated to characterize the problem and best understand how we could intervene. Regulatory agencies and Congress were ready to act on the researchers' findings and their recommendations. After a short time, the intervention halted the rise in death. With ups and downs, including factors like the economy, changes in road and car design, policies about alcohol, deaths from crashes continued to fall. We saw a greater than 60% per capita decrease and a greater than 80% decrease accounting for the overall increase in miles traveled. In 1999, CDC called this a 20th century public health achievement. With firearms, we've done the opposite. The federal government, instead of promoting and funding research, has largely abdicated its responsibility. The result? Rates of firearm mortality haven't declined. In fact, we've just seen these trend lines cross for the first time in history.
To best understand the risk of firearm injury and death, and potential interventions to prevent it, let's first look at who's dying from firearms and why. There's a general misconception that firearm homicides outnumber firearm suicides, and perhaps that leads many clinicians to think there's not much they can do to make a difference. However, suicide accounted for nearly 60% of deaths from firearms in the United States in the most recent annual data available, even when firearm homicide rates were at their highest in the late 1980s and early 1990s. Firearm suicide rates were higher. The steady increase in firearm suicide and decrease in firearm homicide over most of the last 2 decades meant that there was effectively no net change in firearm deaths. More recently, as we've said, both suicide and homicide have been increasing.
Overall, males are at much higher risk for firearm death, both homicide and suicide. This graph is one you're familiar with, even if you've never seen it before. It shows the most up-to-date death rates from firearm homicide among males by age and race or ethnicity. Note that young black males' firearm death rate is more than 5 times as high as that of young Hispanic males, and more than 8 times that of young white males. I'm not aware of another major medical or public health problem for which risk is so concentrated among a specific age and race group as firearm homicide is for young black men.
It's important to emphasize that females are also at risk. While black females in the 20 to 24 age group had a rate less than 10% that for black males in that age group, the homicide rate for black females from birth through age 39 exceeded that for white males of the same age. This chart you might be less familiar with. It shows the recent annual rates of suicide among men by age and race. White, non-Hispanic men are at highest risk, and not only does the rate increase with age, it increases more rapidly with age. We know that in recent years, between 85 to 90% of firearm-related deaths among black men were homicide. Between 85 and 90% of those among white men are suicide. Let's also quickly take a look at rates of firearm-related mortality among children and adolescents. Although the unintentional firearm death rate remains pretty stable for youth through age 21, rates for firearm homicide and suicide both begin steady increases around age 12. We may have a unique opportunity to intervene and prevent future firearm injury and death in that period in which the rates remain low while children are relatively young. This is the traditional public health approach to the problem. We've been talking about risk, which we all know is critical for prevention efforts. High-risk groups deserve our attention. There is a complementary approach, however, called the population health approach. The population health approach is based on the observation that most adverse health events, the burden of illness, can occur among people at low risk if the low-risk population is big enough.
Heart attacks are a good analogy. Many people who have a heart attack have just a few risk factors. A comprehensive prevention approach should be both risk-based and population-based. When we look at total number of deaths from firearm injury, we see that after the mid-30s, the burden shifts from black men to white men. It's important to keep this broader picture in mind as we prepare to discuss firearms with our patients. What can we do as providers? First, we can identify risk. Second, we can counsel patients who are at risk, just as we counsel patients on healthy behaviors and risk reduction for other health problems. And finally, we can act when someone is in imminent danger.
Let us be clear, we're not recommending that docs talk to every patient about this. Discussions about firearm access are not always relevant. Rather, we should have the discussions when, in our professional judgment, it's most relevant to the health of the patient or others. To know when it's directly relevant, we need to be comfortable in identifying risk factors among our patients. As we'll see, the reason a patient is at risk for firearm-related harms might well be what has brought them in for care.
At-risk patients may belong to a demographic group that's at higher risk, may have histories or individual characteristics associated with an increased risk of violence, or may have active suicidal or homicidal ideation or intent. Keep in mind that the patients we're seeing might not be themselves at risk for committing harm with a firearm, but instead may be the partner, family or household member, or caretaker of the at-risk person. The patient might not be the firearm owner either, but it's still critical to have the conversation when someone in the home is at risk.
Let's look at the three risk groups in detail. Some patients fall into demographic groups that are at higher risk for firearm-related harm. These include children and adolescents for unintentional firearm injury, adolescent and young adult men for homicide, middle-aged and older men for suicide.
There are also patients who will have individual risk factors for firearm injury and death. These patients may have a personal history of violent behavior or of violent victimization, abusive partners, problems with misuse of drugs or alcohol, serious or poorly controlled mental illness, although it's important to mention that patients with mental illness are unlikely to hurt others. They're more likely to hurt themselves, or impaired cognition or judgment.
There's specific evidence on these individual risk factors. For example, having a firearm in the home increases risk of death for victims of intimate partner violence by 5 times, even if the victim owns the firearm. Among legally authorized firearm owners, a prior history of violence increases the risk of future violence by 5 to 15 times. A prior history of alcohol abuse increases risk by about 4 times. Substance misuse, whether of alcohol, drugs, or both, increases risk of unintentional firearm injury, suicide, and homicide. Cognitive impairment also increases risk for all these types of violence. So far as is known, the prevalence of firearm ownership among people with these individual risk factors is about the same as it is in the general population.
Finally, let's consider patients at acute risk for violence, patients with suicidal or homicidal ideation or intent. When a patient expresses suicidal or homicidal thoughts, it might be an emergency, and it can be critical to take immediate action.
Here's one important takeaway. Method or means by which a patient attempts suicide has a big influence on whether they survive. About 90% of firearm suicide attempts are fatal. Suicide attempts by other means are only fatal about 10% of the time. Most importantly, research shows that 9 out of 10 people who survive a first suicide attempt will not go on to die by suicide. So, if we can keep them from dying in their first attempt, they're likely to live a normal and healthy life. Here's another important takeaway. Our message as healthcare providers should be to reduce firearm access for those who are at risk of injury or death.
And other messages might be relevant too. For example, some patients may want advice from providers on whether or not to get a firearm. And providers might want to counsel some patients to not have firearms in the home at all, as the American Academy of Pediatrics recommends. But for patients with firearms, the conversation might be as simple as counseling on the importance of safe storage practices and on reducing access temporarily when someone is going through a time of crisis.
The first step to counseling is to plan a tailored conversation. We should consider what we already know about the patient and his or her risk factors for firearm injury and death. Counseling should be respectful and non-judgmental, relate clearly to the patient's health and well-being, be conversational and educational, acknowledge local firearms customs, and include appropriate follow-up.
Emphasize that risk for firearm-related injury is not static. It changes as circumstances in the home change. For example, maybe a patient has had a firearm for years but recently had a child. You could remind the patient that safe firearm storage is important for reducing risk of unintentional firearm injury among children. When discussing firearms with patients, the language we use is also important. For example, we encourage using the word firearm, though gun is acceptable in many cases. Awareness of local firearm culture, respect for reasons for ownership, and a shared decision-making approach are all important parts of the conversations we have with our patients about firearms.
We'll need to explain why we're asking about firearms. That is, why risk is increased and why firearms in this case are a matter of patient safety and well-being. We can mention the specific risk factors we've identified in our conversation with the patient. That way, the patient will see the conversation as relevant and understand the emphasis on safer storage.
It may be appropriate to talk about risk in general. If so, we can explain that, on balance, a firearm in the home increases the risk of death for everyone in the home. On average, even after controlling for socioeconomic and other demographic variables, when there's a firearm in the home, risk for homicide in the home goes up by a factor of 2.7, and risk for suicide in the home goes up by 4.8, compared with homes without a firearm. Of course, these risk numbers are based on population-level data and may not apply to your individual patient. They also may not be appropriate to mention during an individual visit. Some providers feel uncomfortable or uncertain starting a conversation about firearms, so we're going to walk through some suggested approaches.
If I've determined that the patient or someone in the home is at increased risk for injury from firearms, I know that asking about access to firearms is important. I'll say something like, in situations like this, I think about safety and need to be concerned about ways an injury could happen, including access to firearms and other weapons. So, for example, are there any firearms in or around your home? Or I could just assume there is access and instead of asking a question, just say, so, for example, tell me about the firearms in your home. With this phrasing, I've established a context that makes the question relevant to the patient's health, just as the other risks I've screened for are relevant. The vast majority of patients are entirely willing to talk about firearms with their providers when they feel it's relevant to their health or the health of someone in their home. If the patient I'm seeing has none of the risk factors and is not at risk because of someone else, I personally don't ask about firearms. I screen for firearms when there is a specific indication. You might choose to screen more generally.
If a patient is at risk of injuring themselves or someone else, and they have access to a firearm, There are several important follow-up questions to ask about. Who can access the firearms, how the firearms are stored, and who the firearms belong to. This will help us assess the level of risk and determine how best to counsel the patient to reduce risk. Knowing who has access and what the current storage practices are will help you make concrete recommendations for reducing the risk of injury or death. Finding out who owns the firearms is important, so we can get a sense of who makes the decisions about how they are stored and what potential we have to ensure those storage practices are safe.
When we're planning a counseling approach, we'll obviously want to be ready to answer the patient's questions about firearms. This could include questions about how to store firearms safely, what to do if a patient is worried about someone else's firearm access, how to address firearms and safe storage in other homes where the patient's children spend time, and where to learn more about firearm laws in your state. Our recommendations regarding firearms will vary from patient to patient. If I learn from a patient that not all firearms in the home are stored securely, but that no one in the home is going through a tough time or a period of crisis, I simply aim to discuss safe firearm storage options and then plan to follow up at the patient's next visit. Let's take a look at what safe firearm storage means. Store firearms unloaded, store firearms and ammunition locked up and ideally separate from each other. Assume that children know the location of firearms and ammunition in the home. Keep the keys or combinations to firearm locking devices inaccessible to children and other high-risk people. There are a variety of safe storage devices for firearms, and the right one for each patient will vary depending on what type of firearms they own and the reasons for owning those firearms.
Let's walk through a few different devices firearm owners can use to safely store a semi-automatic pistol, a common type of handgun. Before locking up a firearm, it's important to know that it's unloaded. To do so, first remove the magazine, then open the slide and make sure there isn't a cartridge in the chamber. A cable lock is the most inexpensive and widely available type of locking device. In some areas, cable locks are given away for free by law enforcement agencies. While cable locks may not prevent theft, they can prevent unauthorized or accidental use of a firearm. To use a cable lock, first lock the action of the gun open. Then put the cable through the magazine well and out the ejection port. Finally, lock the cable and remove the key. At this point, the pistol cannot be loaded, nor can it be fired. Another inexpensive locking device is a trigger lock. Before using a trigger lock, make sure the firearm is not loaded. To use a trigger lock, first separate the lock into two pieces. Insert the cylinder through the trigger guard behind the trigger so that it cannot be pulled. Then attach the second piece and lock the device. Similarly to cable locks, trigger locks may not prevent theft, but they can prevent unauthorized users from firing the firearm. Another safe storage device is a lockbox. Lockboxes are more expensive than trigger locks and cable locks, but they may better protect against theft, and they keep firearms out of sight. A lockbox is a small safe, which locks a handgun inside using a combination keypad, key, or biometric or fingerprint technology. Firearms stored in lockboxes should be stored unloaded. Many lockboxes come with a security cable that allow you to anchor them to a secure fixture. Firearm owners may opt to use a firearm safe to safely store firearms. They may accommodate multiple firearms and firearms of various sizes. To use a firearm safe, be sure that all firearms are unloaded before placing them inside. Then lock the safe with a combination, a keypad, or biometric technology. Ammunition should be stored separately from firearms and also locked up. Be sure to keep the keys and combinations to firearm safe storage devices away from all unauthorized users. Some storage devices that are suitable for long guns, like rifles or shotguns, look a little different, but they generally function the same way. Remember, if you learn that there are firearms in the home but no one is at risk, you can use your counseling to promote safe storage using devices like the ones we've just seen.
I might learn during the course of my normal questions about risk that someone is at extreme risk of firearm injury or death. To keep the patient or others in the home safe, I might decide to make referrals to social services, mental health services, or programs for patients with substance use disorders. The patient or their family may need specific counseling on how to reduce access to firearms while they are at highest risk. And in certain circumstances, I may need to contact local law enforcement or the patient's family. No matter where you work, HIPAA regulations expressly allow disclosure of ordinarily confidential information when a person is at imminent risk.
In situations like these, we can recommend that firearms be temporarily stored outside the home. This might be available on a voluntary basis at gun stores, shooting ranges, or local law enforcement agencies. And in some states, firearms may be stored with trusted family members or friends. An increasing number of states allow for gun violence restraining orders, also called extreme risk protection orders, which allow for firearm recovery by law enforcement under specific conditions involving an imminent threat. As providers, we should be sure to know what options are available in our areas. Putting time and space between a person in crisis and firearms can be life-saving.
Consider the following scenario. An older male visits his primary care doctor for routine checkup. In conversation, his primary care doctor learns that the patient is depressed and drinking more than usual. His wife has recently passed away. He reports having reduced social interaction. In this case, the provider requests a psychiatric consult. You might be comfortable caring for this case without a consultant. Let's see what happens.
So, Mr. Johnson, what brings you here to see me today?
I don't know, maybe depression. My wife died recently. I really miss her. I'm kind of on my own now, and work isn't going too well. And I'm drinking too much.
How much do you drink on an average day?
A few beers, I don't know, maybe a 6-pack, maybe more.
Some people with depression find that drinking makes their depression worse. Do you ever find when you're drinking that you feel more sad and you get down in a really bad place?
Yeah, I guess so. I mean, I don't feel that way now, but.
How far do you ever get into that dark place? Do you ever think about actually ending your life, or have you taken steps to do it?
Yeah, I have some guns at home, and I thought about doing something with them.
Let's talk about your guns. What do you have at home?
I hunt, so I have a couple shotguns, a couple rifles, and a handgun for target, and one to defend myself. And I just keep it in the nightstand.
Sounds like you always have one loaded and pretty close at hand. And you say you want to live now, but do you ever worry that you might feel differently?
Sometimes I when I'm drinking, I get into a pretty dark place.
Is there a safer place you could keep your guns? Like maybe a friend that you could give them to until you're feeling a little bit better?
Oh, I need them for protection. I need my gun.
I mean, I hear that, but as your doctor, I actually think that your guns are making you a lot less safe right now. I'm really worried you might go home, be by yourself, start drinking, have your depression get worse, and maybe use one on yourself. And that's the kind of decision that you don't get a chance to rethink later. Can we talk about ways to prevent something like that from happening?
I just don't want to be one of those people that can't have a gun the rest of his life.
I don't think that's necessary, but I do think it's really important right now with your circumstances to put some time and distance between you and your guns.
I think you're right.
I'm glad we're on the same page about this.
When you're counseling a patient who's going through a tough time and has access to firearms, the approach you take to counseling might be especially important. You can emphasize that your aim is to make the patient safe in the short term until the crisis passes. In cases like the one we just saw, we're concerned about high risk of suicide with both the impulsivity of attempting suicide and the lethality of firearms in mind. Temporarily storing firearms outside the home can be a good way to increase safety. After you've made recommendations to patients, whether or not it is an extreme risk situation, remember to follow up. Find out whether the patient acted on your safe firearm recommendations and why, or why not. Remember that circumstances change, and that means risk is not static. We've created materials for you to use in a clinical setting. The handout for providers details considerations for evaluating risk and tailoring the firearms conversation for each patient. Send the patient handout home after you've had the firearms conversation as a reminder of why firearms in the home are risks and what they can do to reduce risk for everyone in the home. The handouts are available on our website. While it's important to understand the policies in our states that might be relevant to discussing firearms with our patients, we can be very clear that you can ask. There are no state or federal statutes that prohibit us as providers from asking our patients about firearms when it is in the interest of their health and safety or the health and safety of someone living or spending time in the patient's home. You might have heard of so-called gag laws, particularly in Florida, where the Firearm Owners Privacy Act was widely misinterpreted as preventing providers from asking about firearms. That law, however, specifically permitted a provider to ask if the provider, and I'm quoting here, in good faith believes that this information is relevant to the patient's medical care or safety, or to the safety of others. And it's no longer on the books. In 2017, it was declared an infringement of freedom of speech and overturned by the U.S. Court of Appeals. The Affordable Care Act includes language on asking about firearms, but only to the extent that it prohibits required collection of firearms information by wellness and health promotion programs. So not only can we ask, but when necessary, we can disclose the information we receive and we can intervene.
The HIPAA privacy rule says that a patient's health information may be disclosed when, quote, necessary to prevent or lessen a serious and imminent threat to the health or safety of a person or the public, end quote, and when the disclosure is, quote, to a person or persons reasonably able to prevent or lessen the threat, end quote. This disclosure can, when relevant, include information about firearms. Imminent is not precisely defined, but in studies of violence, it's often taken as meaning anything from a few days to months. Elsewhere in the Code of Federal Regulations, an imminent hazard is one that could cause harm before a federal regulatory agency is able to take formal action. When there is serious and imminent threat, we can intervene.
Many states, including 8 just in 2018, have enacted policies for recovering firearms from their owners when an owner has demonstrated extreme risk. These are commonly called extreme risk protection orders or gun violence restraining orders, and elements of the policies vary from state to state. Extreme risk protection orders are civil court actions and can be used in cases in which an individual has exhibited dangerous or threatening behavior, has access to firearms, and isn't otherwise prohibited from having them.
We'll use California as an example. In California, GVRO procedures are based on those used for domestic violence restraining orders. To get a GVRO for someone, a petitioner, who can be a law enforcement officer, an immediate family member, or a household member, must file a petition presenting evidence for why the respondent is an imminent threat to self or to others.
A judge reviews the petition, and if an order is granted, firearms can be recovered for up to 3 weeks. During those 3 weeks, a judge can hear the case and decide whether to extend or cancel the order.
When the order is canceled or expires, the respondent can request to reclaim his or her firearms. These protective orders do not affect individuals' abilities to own or purchase firearms in the future, as long as they are not otherwise prohibited from doing so.
There are encouraging results from Connecticut and Indiana, which have had similar policies in place since 1999 and 2005, particularly regarding suicide.
In both states, researchers estimate that a life is saved for every 10 orders issued. That's a number needed to treat of 10 for preventing a patient's death.
Though in most states as providers we can't petition for these types of orders, we can let law enforcement or family members know if we think there is imminent risk and intervention such as this is necessary.
Resources that can help with understanding state firearm laws include the Giffords Law Center and the RAND Corporation's new state firearm law database. It can be important for us to generally know our state's policies and to be able to point patients toward the state's firearm policies if they ask.
There are challenges to counseling, even though providers appear to overwhelmingly feel it's within our scope of practice and it's relevant to the health and safety of at-risk patients and their loved ones. Time may be the biggest challenge. I certainly feel time pressures when I'm at work. But remember, we're not recommending universal counseling. We're recommending that when risk factors are present and firearm access is directly relevant to the health of the patient or someone in the patient's home, that you take the time to talk about it. It can be brief, non-judgmental, collaborative conversation with concrete recommendations to reduce risk.
Another common barrier is that you might be uncomfortable asking. If this is the case, consider all the private and sensitive questions you're accustomed to asking patients about their personal habits, their drinking and drug use, their sexual history. Plan your approach and practice the questions about firearms to make sure you're comfortable in the exam room when you're speaking with an at-risk patient. You might believe you don't know enough about the topic. We've heard this often. Historically, providers haven't been trained to evaluate risk for firearm injury or counsel on firearm safety.
We're working on this, though. More and more research and more funding is being put into understanding firearm injury and death from a health perspective and developing targeted interventions, including clinical interventions, for firearm injury prevention. And for now, there's the What You Can Do initiative and other resources on the provider's role in preventing firearm-related harm.
You can join thousands of other providers across the country in making the public commitment to counseling your patients. Visit the article, What You Can Do to Stop Firearm Violence, at Annals of Internal Medicine online, and click Make Your Commitment Now.
We vary widely in our experience with firearms and our opinions about them. But I suspect the great majority of us have had clinical experience with firearm injury or its consequences. It's this common experience of treating the victims of firearm-related harm that reminds us of the importance of prevention. Healthcare providers have a unique role. You are committed to your patient's health, and you have opportunities every day to talk with patients about risk and safety.
Prevention is the best strategy here. Remember that most of those who die from gunshot wounds do so at the scene of the shooting. There's no opportunity to intervene once the injury has occurred. Survivors' lives are often irreversibly altered physically, psychologically, emotionally, and economically.
The following professional organizations have issued statements on firearm violence as a health problem. Their logos appear here with permission. If you're looking for more information on firearm injury and death, epidemiology, interventions, patient receptivity, identifying risk factors, planning a counseling approach, you can find many of the answers on the What You Can Do initiative website. And if you can't find your answer there, please send us an email and we'll help you out.
Thanks for watching. We hope to hear from you as you make a commitment to asking about firearm access when risk factors are present and counseling your patients when indicated. Please let us know how it's going and what we can do to help. Thank you.
Support for the University of California, Davis Violence Prevention Research Program comes from the Heising-Simons Foundation, the Fund for a Safer Future, the California Wellness Foundation, and the Joyce Foundation. Support for UCFC, the University of California Firearm Violence Research Center, comes from the state of California.